Hello everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Ava Kelly. This week, we again have a presentation from the Medicine in the Mediterranean Conference from last January. We have our very own Vice Dean of the College, Eric Bauer, who talks about the PHACTORS mnemonic for organizing the post-intubation patient.
I'll hit on a few of those areas as I talk, but I want to talk about one of the big topics around the world right now is how do we manage patients in the post-intubation phase? I came up with this acronym really based on some problems that we're seeing in the United States, where we're still seeing a lot of post-intubation hypotension, regardless of maybe lowering ketamine dosing and really doing a good job with resuscitation. Worked with Scott Weingard on this to try to perfect this acronym, and it's something we're going to write a paper on in the future. So I wanted to share this with you because I think it's timely. When we think about defining the post-intubation phase, the key thing in the United States, there's something that all air medical programs have to report monthly, and it's called GAMET data, ground and air medical transport data, that really puts all programs against each other to look at best practices. And I think it's a great program, and they have a metric called -1A. And -1A is just a metric that really is defined as looking at somebody in the 10-minute phase before intubation, the 10-minute phase after intubation, and asking, do we have any peri-intubation hypoxia or hypotension? After intubation, do we have any post-intubation hypoxia or hypotension? And so that is actually defining first pass success. So let me give you an example. You intubate a patient, you have a peri-intubation blood pressure of 88/50. SAT of 94%. You intubate that patient, that flight crew or critical care crew, that would be deemed as a failed attempt because they intubated a patient that was hypotensive. It doesn't matter if the intubation went successfully, if the cords were visible immediately, and we had an ET2 placed with confirmation of end-tidal CO2. So it is a really, really high standard focus on making sure that we're hitting on those life threats. What do you guys think about that? Are those standards too high? I don't think they are. But I think we've really focused on this to the extent where we're still seeing hypotension in the post-intubation phase. So I wanted to come up with and talk about really why that happens. And -1A is defined as the blood pressure has to be greater than 90 systolic, and our SpO2 needs to be greater than 90%, okay? So obviously we're gonna resuscitate above those metrics. And so what programs are really doing is they're not hitting 90%, they're trying to focus on a systolic of 100. And a systolic of 100 is really the goal. SpO2 94% or greater. Then you pull the trigger. So what causes somebody to decline is really the focus of the factors. And I think we've done a good job in the peri-intubation phase. I think we've done a good job with education over the years in the resuscitation process, peri-intubation. We haven't done a good job in the post-intubation phase, and really that is where this talk is focusing on. What happens after we have success? And we're missing this critical piece. This critical piece really is summed up by Napoleon, who says the most dangerous moment comes with victory. We've intubated the patient, it's a win, first pass success, everything is good, and we let our guard down. Or do we? Are there factors, no pun intended, that impact that post-intubation 10 minutes? Because again, let's say you do resuscitate, you resuscitate to a systolic of 100, our SpO2 is 96%, we have first pass success, we've secured the ET tube, we have good waveform capnography. 5 minutes later, hypotension. that's also deemed, based on -1A, as a failed attempt. So it's looked at all the way up to that 10-minute mark. And talking to Scott Weingart about this, he kind of laughed at me. He said, that post-intubation 10 minutes, that's difficult. He goes, I don't know if I agree with that. 10 minutes is a long time. A lot can happen in 10 minutes after intubation. And he may or may not be right. That is the current standard, though. And so let's talk about those areas. This is not working. The first thing is positive pressure. Factors, P, positive pressure. Well, obviously we have to ventilate our patient, don't we? And we ventilate our patient in multiple ways. That's not even talking about ventilating our patient in the peri-intubation phase, where we know that the standard of care has moved to passive oxygenation techniques, maybe withholding a BVM, using it as a last-ditch effort. But what about after our intubation is successful? How does positive pressure ventilation impact our patient's hemodynamic status? And so that is where, when we look at, there is definite research, evidence base to support the impact of positive pressure. Now, it's inevitable. We have to perform positive pressure ventilation. But what is the best way to do that? It's with a mechanical ventilator. And many of us, based on maybe where we're at, how we transition after intubation, we're using our BVM. Well, what's the impact? Well, we know based on standard negative pressure breathing, when we drop our diaphragm, negative intrathoracic pressure, that volume goes in, it actually optimizes forward flow. It optimizes preload. It is really good for your right atrium and right ventricle. When you then transition a patient to positive pressure, you limit this process. Preload drops. That positive pressure impacts your patient. And that's not even considering maybe the current disease process, why you're there, how the patient's heart is currently. Are they already in a cardiogenic type shock? What type of shock state are they in? So a lot of us use this, don't we? I call this the lethal weapon, because we all need to have continuous education on performing good quality BVM ventilations. And there's been a lot of great studies out there where they demonstrate, it doesn't matter if you're an EMT, an EMR, a paramedic, a nurse, or a physician, if you test them, we do poorly. Even knowing you're going to be tested, you still do poorly. And so what do? We bag too fast. We squeeze too hard. We start going to the beat of our heart. Or we start talking to a colleague and start bagging too quick. And so we start driving up those inspiratory pressures. Once we get above 20, we know a lot of that volume passes the lungs and goes to the stomach. That impacts our cardiac output alone. So how much volume does a BVM deliver? If you're using two hands, and we know the evidence says up to 1,500 mils can be delivered in one breath. Do we need that much? No. So that's a big problem. And so what's the solution? The solution really comes down to transitioning to a mechanical ventilator as quickly as possible. Now, I know that that's not always available. But if it is available, we have to do a good job in thinking about maybe changing our practice. And I'll give you an example where I see this really impactful. In the US, when you talk about flight crews, if they intubate in a hospital, they're going bedside to bedside, they have their ventilator with them. But if we land on scene of a scene flight, and we're dealing with a multi-systems trauma patient, and we go to the back of the ambulance, most flight crews are leaving that vent in the helicopter. And they're bagging back to the helicopter. And that's a really important phase. And so could we reduce the impact by having consistent tidal volumes, consistent rates, gauging our inspiratory pressure, optimizing FiO2 immediately? Could be beneficial. But now you're dealing with another piece of equipment. And that's something that is usually the argument. I don't want to have to deal with something else. Moving on, when we think about factors, H stands for hypoxia. Hypoxemia. Why are you there? And again, this is an evaluation. This is a mnemonic to use to evaluate, hey, we have a decline in my patient. We have an SpO2 that is all of a sudden plummeted. What is going on? And so when you think about de-recruitment, you think about overall adult BVM to your ventilator. Well, how would that cause hypoxia? Think about moving your patient from a supine position to head of bed elevated. That's one of the simplest things to recruit lung. And then the overall patho, why are you there? Why did you get called to the scene or to the hospital for transfer? So let's talk about de-recruitment. How does de-recruitment happen? What I would say is we've done a good job again in the peri-intubation phase to say, hey, we need to use PEEP with every single breath. Add PEEP to your PEEP valves to your BVMs. If you're going to use a BVM, have PEEP valves applied. And I know a lot of programs in the US actually call for 5, some 10 a PEEP on every patient. Because we know PEEP does a lot of good in improving surface area, thinning out the alveolar membrane, allowing for more area for gas exchange. And so PEEP is our friend if it's used in the correct ways. So if you have 8 to 10 a PEEP on your patient, you take the patient off your BVM to your ventilator, are you guys clamping your ET tube? I guarantee I forget all the time. It's just something that, we've done a good job ventilator to ventilator on higher PEEPs, but we forget to do it from BVM to ventilator. So that is going to cause de-recruitment. De-recruitment is also going to segue to adult BVMs to your ventilator. I just said that if you're using a BVM incorrectly, a lot of us do this, we don't think about it, we're using 2 hands, we're giving these big massive breaths, and then you set your tidal volumes at 6 mils per kilo, and you go from a 1,500 mil breath to a 70 kilo male at 420 mils. That's 1,000 mil reduction. Remember, the breath is what recruits lung. So you're going to have a significant de-recruitment just by moving from one method to another. Don't forget to lift your heads. Put your head elevated at 30 degrees. Most patients will tolerate this. Very, very easy to improve overall recruitment. Go through a quick dope mnemonic. You have a dropping SpO2, make sure you don't have anything that's obvious that you can fix. And this is 15 to 30 seconds. Right? Make sure you don't have any dislodgements. Do you have any obstructions? Have you suctioned the ET tube? Are you stepping on the vent circuit? I've done that before. Right? All of a sudden, high pressure alarm goes off. Do you have all the lines connected to your ventilator? Do you have a disconnection? That was one of the problems with the LTV 1200. If you ever use that ventilator, the little clear tubing would pop off and you would lose all oxygen in delivery. And then just look at your equipment. Again, move through this rapidly. Pneumothorax is one of those things that I think is you should be aware of what's going on. If you have mechanism, if you have indications your patient could have a pneumo, you should have already suspected, assessed that. You have a simple pneumo, be prepared to look at your ventilator alarms, your PIP, your P-plat, if you have a volume ventilator. So that should not be a surprise to you. A is something we're going to move through real quickly, guys, and what I would say here is we saw this in COVID. I think mechanical ventilation in general is a topic of itself. But you have to have a good understanding of your patient. And you get a patient and you walk in and you all of a sudden see a decline in your patient, blood pressure drops, SpO2 drops, patient starts crashing. What was the peri-intubation respiratory rate? If you have an ABG in front of you and you can identify it through history and ABG that they're in a partially compensated metabolic acidosis, then obviously you can set that rate to match that compensation, but always just be cognizant, be suspicious, identify what that peri-intubation respiratory rate was. And really the three that come into Goldmark. Goldmark is an acronym, I don't know if it's new to you. It really has replaced cat mud piles. It's a great mnemonic in identifying acidemia, the cause of acidemia, so you can start focusing on resuscitation. But when you start thinking about what types of causes would cause partial compensation, it would be ethylene glycol poisoning. It would be patients with aspirin overdose, methanol overdose specifically, and then ketoacidosis. Those are the ones. I think we loosely say metabolic acidosis leads to compensation. I think that's probably a loose way of saying that. I think it's more deliberate. There are specific etiologies that cause that. But just be cognizant that you rule in or out acidemia. C, cardiac output. Cardiac output has already been addressed a little bit in our first slide where we started talking about positive pressure. We're already impacting positive or cardiac output with poor venous return, the negative pressures that are impacting the right atrium and ventricle. But what are you doing to augment that? Understanding stroke volume. Stroke volume is one of those things that I think we learn, whether you're a nurse or a paramedic. When you first start out, we learn stroke volume, but do we truly know how to identify and look at each element of stroke volume? Right, we got some heart rate. So heart rate's too fast, too slow, it's just right. Remember, tachycardia, though, is anything 220 minus your age. So don't get sucked down the rabbit hole of a high heart rate of 190 on a 20-year-old male. That could definitely be sinus tach. So any sinus tachs, always rule out the 3 H's. Are they hypoxic? Are they hypovolemic? Are they hyperthermic? Before you go down the ACLS route of, hey, it's SVT. But stroke volume is preload. How can you affect preload positively and negatively? Right? We can do passive leg raising to identify volume status. We can use IVC claps with our ultrasound. Meaning we want to be diligent, give fluid if needed, but don't just dump 3 liters of fluid in somebody if they don't need it. Maybe they're not volume responsive. Start your vasopressors early. Okay? What about push dose pressors? We're going to hit on that. And then we have afterload contractility. And afterload is one of those things, again, you got to look at the past medical history. Does this patient have a restrictive cardiomyopathy that's underlying that you weren't aware of? They have this high afterload state, high SVR, high left ventricular end diastolic pressure, and this patient's hemodynamic status is compromised, maybe giving dobutamine, maybe giving milrinone, maybe giving something that's going to support their contractility, their inotropy, vasodilate their SVR a little bit, will impact their cardiac output positively. And contractility comes with that as well. And then overall cerebral perfusion pressure, guys, thinking about coronary perfusion pressure, cerebral perfusion pressure, that comes with good overall perfusion and cardiac output. And so we need to be aggressive and ahead of the game. And this is the key, is it's a sweet spot. Hey, you've got this blood pressure, post-intubation right at 90 systolic. It's time to give a push dose pressor, especially if you're transitioning some fluid or you're starting blood products or starting something. You've got to be ahead of the game. You've got to have that mixed up. Whether that's epi, phenylephrine, we're using vasopressin in the US for push dose pressor, right, in the aeromedical side. And that has been shown through a study called the Viper study to be much better in trauma over phenylephrine and epinephrine. So again, whatever you have available is going to be warranted, but use this, be cognizant of that consistent impact, and understand you need to use this multiple times. Transfer. Guys, this is where I came up with this idea. Is there's that 10-minute phase, and if you remember the title, Platinum 10, where does that come from? Way back. Flightbird Jed, if you don't know, Flightbird Jed was founded off of a podcast called the Flightbird Jed Podcast. And one of the first podcasts I did was called the Platinum 10, and it was really a talk to really say, hey, we need to be off the ground in an aeromedical environment in 10 minutes, intubate in flight. And we've changed that now, and all the evidence supports that that's not the best thing to do. That we actually rush it. Rushing leads to poor outcomes. Maybe staying on scene an extra 10 minutes is better for our patient. Resuscitation is better for your patient. So the transfer phase is this dead area. It's this area that we're focusing on other things. We're not focusing on the patient. What's happening here? We're looking eyes out. We're looking for towers, wires. We're looking for obstacles. We're watching the mountain, right? No matter where you are lifting off, you're not focusing on the patient. You're focusing on safety. You're focusing on communicating with your pilot and your partner. And the patient comes second. And so it comes down to situational awareness. Think about landing in these really rural environments with a lot of trees, wires. You have to move to the helicopter. You're loading your patient in a hot environment. Rotor systems are moving. Are you focusing on, can you hear, can you assess your patient at the same level that you could at the bedside or in the back of the ambulance? The answer is no. You're focusing on not having somebody walk into the tail rotor, right? You're making sure nothing's flying up into the rotor system. You're focusing on these other safety elements. And so transfer is a big thing. We have to, again, be prepared to say, hey, I am going to make sure I've got my push-to suppressor. Let's give it before we move. Do I have sedation before we move? Are we ready to move? Do you have everything reassessed? And that leads to ongoing pharmacology. A lot of places around the U.S. have moved, and I don't know if it's been this way in Europe, but we're using more of a longer acting paralytic like rocuronium instead of succinylcholine. And so your paralyzation is 20 to 30 minutes. And it's really easy if you've used a short acting paralytic for your career to start focusing on movement early to say, hey, I've got to give sedation pain management. And you're like, I don't want them waking up going through the door. So I'm going to be diligent in giving this early. And I think we've seen this across the board. I've made this mistake myself where, you're giving ketamine as well. Etomidate was used primarily, and etomidate has a short half-life. And so we're using longer acting drugs that are maybe 10 or 15 minutes in total dose. And so you're seeing a change to where we need to be a little bit more ahead of the game with our sedation pain management. Again, it comes down to just being good and providing good care. And what I would say with airway management, and you guys may have reflected on your own career, airway management works well when we're proactive, not reactive. If we're reactive to situations in airway management, it leads to mistakes. It leads to poor outcomes. It leads to bad things. So it's always better to be proactive, trying to see things 2 or 3 steps ahead. R is resuscitation. We've already started resuscitation in the peri-intubation phase. We have to continue that. We can't stop. Have to keep moving forward. So how do we get a good index of suspicion that, hey, my patient is doing poor or likely to do poor? We use shock index. And shock index is one of the areas we've really focused on to say, hey, our ketamine dose of 2 milligrams per kilo, even though that sounds great, that's the higher end of the dose for your RSI, we don't need all that. There's been some good papers. Cliff Reed did a paper quite a few years ago highlighting the potential hypotensive effects of ketamine. It was early, it was observational, but I think that paper has been proven correct. That these big doses, right? How does ketamine work? Why do we love ketamine? Well, it works because it blocks parasympathetic receptors, which causes a rebound sympathetic response. Gives us a bump in heart rate, gives us a bump in blood pressure. But if they're already catecholamine maxed out and they can't handle that bump, what happens? They crash. So what we've seen is if you have a shock index equal to or greater than 0.9, really the standard is lower the dose to 1 milligram per kilo. I've got a few programs I'm working with that are actually lowering it even lower. Their normal dose is now 1 milligram per kilo. Their high shock index dose is 0.5 milligram per kilo. Just enough to dissociate them, that's all they need. Because again, we're still seeing post-intubation hypotension. And I don't know what it is. I've worked with multiple physicians on this. They don't know what it is. Is it the positive pressure ventilation? Is that something that we're worried about, that we can fix, that we can make a difference? But again, we got to continue the resuscitation. If you started blood products early, you started volume early, right? Are you transitioning to vasopressor support? Are you transitioning to more blood products? Are you reevaluating the need for push dose pressors? Again, it doesn't stop. You got to continue. And even though we're talking about the 10-minute phase before and the 10-minute phase after, that doesn't mean we can stop. We keep going. It's just that is what first pass success is evaluated on. 10 minutes before, 10 minutes after. And lastly, guys, when we think about factors, it's good BLS and ALS care. It's suctioning your patient and thinking about the impact of suction and thinking about, are we controlling their secretions? Every patient should be suctioned. Are we placing an NG or OG tube on every intubated patient? Controlling the gastric fluids. Decompressing the stomach, which impacts cardiac output favorably, right? Good nursing bundles. VAP prevention. Ventilator-associated pneumonia is caused by EMS and emergency department practitioners. And that's not a knock on us, it's inevitable. And that's where, using the salad technique as the first thing we do and the last thing we stop doing during the intubation process is really the key. Even if they're not vomiting, control those gastric secretions. But that needs to be continued and ongoing. Think about mucus plugging. That causing lung collapse, atelectasis. So it's about prevention and how does that impact oxygenation and ventilation. So a lot of this stuff works together, right? This stuff works with hypoxia. And if you become hypoxic, that impacts cardiac output because it impacts Starling's law, right? And all this stuff is going to play together favorably, but it also has a negative impact. In summary, we have to think about positive pressure ventilation. I don't know what the right answer is. I don't know if it's using smaller BVMs, if it's making sure that we're training consistently on a BLS procedure, or is it transitioning to your mechanical ventilator if that's something you have available quicker. Hypoxia, understand we need to drive up that SpO2, cause nitrogen washout in the peri-intubation phase, do a good job with passive oxygenation, but we need to continue evaluating that post-intubation. Look for acidemia, right? Identify, is there a need? What was the peri-intubation respiratory rate? Do you have an ABG in front of you? Looking at those metrics to make good clinical decisions. Cardiac output is already impacted with positive pressure. You should always be thinking about push dose pressor at this point, understanding that preload is likely going to be impacted just using a BVM in that initial phase. And think about the peri-intubation phase. If you have to use a BVM in the passive oxygenation, right? Passive oxygenation is not working. You have to escalate to a BVM. The impact is already made on venous return. The right side of our heart is now impacted. Okay? Think about the transfer phase. Again, that is a really big dead zone. That's where we're focusing on a lot of other things besides our patient. And that's where things can get bad real fast. Load the patient in the ambulance, load the patient in the helicopter, and all of a sudden you look down, blood pressure is cycled, and you're hypotensive, you're hypoxic. So try to prevent that. It's not going to be easy. It's just something to focus on. Ongoing pharmacology should be one of the first things you do after intubation. One of the things I recognized in my own practice was when we moved from, in the US, from succinylcholine to rocuronium as our first line pressor, I found myself in flight the first few times being 10 minutes into flight and realizing we hadn't given any post-intubation sedation, right? We had given ketamine, so we still had something on board. And so what I ended up doing is I recognized that that was a problem. And I started, when I buckled my seatbelt, I would pull my narcs out. And that was something, as we transitioned into level flight, that we were talking about with each other, getting that ready, and that was one of the first things one of us was doing once we got to cruise altitude. Resuscitation starts in the peri-intubation phase. It has to continue. We can't stop. You got to make sure, whether that's blood, fluid, early vasopressor. Again, we're talking medical and trauma patients both, right? The way you're going to approach that is going to be a little different, obviously. And then suctioning your patient is a BLS maneuver that can have a huge impact on your patient. Hopefully this talk was enlightening. It brings up some really big points in that post-intubation phase. Obviously, I think this is one of the biggest areas that we do as pre-hospital providers, whether you're a nurse, a paramedic, or a physician, is we have to make sure, right, we're there for a reason. We don't want to cause secondary problems because of poor resuscitation or poor ongoing management with our patients. Do you have any questions?
Great talk, Eric. Question about the causes of the hypotension and the relatively new factors of CAB. You know, making sure we resuscitate before we manage the airway unless we absolutely have to. My question is, many times what we see, and again, I preface my remarks, I'm a peds person,
yeah.
But we see even in the operating room, because we intubate a lot of kids there, the inpatient meds, even though they're using, you know, normal doses, they drop because now they lost their vasomotor tone, whether it's because you sedated them,
yeah,
or you've given them ketamine, or really any of the drugs. And I'm just wondering if one of the reasons we're getting hypotension is because it just made the tank bigger.
No, I think that's a great point. I'll give you an example. On my way here, I actually was sent a case from a flight clinician that was frustrated, and she said that it was a sepsis patient that had been given 5 liters of fluid by the receiving or referring hospital, was in airway extremis, did not have an ET tube, was not on any BiPAP or anything like that. And so, you know, they calculated shock index. Shock index was actually low. There was not a positive shock index. They gave the 1 milligram per kilo dose of ketamine, which I think was the right thing to do. Well, hindsight 2020, but still, after intubation, pressure dropped to 70. It was 130s, dropped to 70 after intubation. Right, so it's like figuring out what is causing that. And I would love other people in the room to chime in on what you see in your practice, because this is truly a dilemma. This is definitely a problem. And so I sent an email back and I said, well, knowing you knew sepsis, you knew airway compromise, you knew even though 5 liters and blood pressure was his, so that could have been a false, right? You probably should have used the lower dose. Right, and there wasn't really an argument or a response. It was like, yeah, I probably should have. So I don't know. I think, you know, is there vasoplegia? Is there you know, are there, you know, this is another topic. It's anesthesia does a good job of evaluating, you know, is somebody on an ACE inhibitor? Are they on ARB medications? Those 2 drugs right there cause vasoplegia, right? And so we should be looking at that in the peri-intubation phase. But a lot of times we don't have that information. And could that impact maybe how we approach our patient?
Yeah, this is awesome. So I'm an EM doc in States, and I teach paramedics. And I think I run into this all the time. I'm like, I need ketamine, their pressure can't go down.
Yeah.
And I keep thinking about, like, as I'm teaching them, like, we probably need to move away from that paradigm, because I see hypotension in ketamine use a lot. And the EPK study even showed it. I mean, there's some weird groupings,
yeah.
Probably too sick. So I love that you are saying that we should move away from this idea that ketamine gives you blood pressure, and that in these patients it just does not. I wish that I had an answer, but I think that's like, this is like a light bulb for me to say, like, hey, guys, we should be using more ketamine, but don't just assume that their blood pressure won't go down.
Well, you know, there's a podcast I had 3 physicians on. I really kind of bowed out. I felt like as a paramedic, flight paramedic, I really didn't have a way to stand on this, but I was, and I don't want to take you guys' time, but this is a pretty big topic. Anesthesiologist at a UT Health, officer in the military, his name is Chris Stevens, and he wanted to meet with me and say, hey, I want to do a podcast with you, and I'm advocating for non-sedation intubation. Okay? What do you guys think of that? I see all these looks. Okay. Yeah. No, and so I was like, okay, basically crash airway, And I've done a few crash airways in my career, but they have always been like, you have to do something now or the patient's going to die. And I don't know still where I stand, but his thoughts, he had lots of data to support it, was if somebody is obtunded, if their GCS is less than 6, there's no clinical evidence that they remember the procedure. So what I did is I had Jeff Jarvis, I had Stevens, and I had Mike Loria, our chief medical director. I had them do the podcast. I didn't want any part of it. Because my opinion really in that context doesn't really matter, right? Medical direction, you physicians in here, you guys are going to make those decisions. And they brought up some really good points. I highly suggest you guys listen to that podcast because his program in the San Antonio area, he has all of his flight teams and ground. That's where I came up with 0.5 milligram per kilo. That is the standard dose for RSI. He does not allow them to go above that. That is the standard dose because he's seeing the same thing. He's seeing too much of that hypotension. So I don't know. What do you guys think? Is crash airway a warranted thing? Trauma. Yeah.
I think the problem is that we are under-resuscitating people to start with.
Okay.
And so we're dealing with this right now. I don't know. Can you guys hear me? We're dealing with this right now with tactical combat casualty care because, for the longest time it's ABC or March.
Yep.
Where the circulation is coming after the A and the B. And so the things that people are looking for are the obvious things like less than 8 intubate. But what happens when you're in hypovolemic shock?
Yeah.
Well, you're going to have altered mental status. And what they're finding in New Orleans right now is that they're just automatically giving 2 units of blood. Mental status improves, the hypoxia improves, the respiratory rates, all those things, we're looking at chest interventions, those things all improve. And so when you resuscitate well before you take an airway, a lot of the things that we're observing and wondering what's happening is because we're trying to put the cart before the horse because A, B, C, we're doing airway interventions, we're doing breathing interventions before we're adequately resuscitating. We just had a case a couple of weeks ago where a 7-year-old lady stopped breathing. They think had a head injury. It was after post-MBC, and she was hypoxic. The head injury, I believe, and the paramedic just did no medication, just intubated her, and then chased it with ketamine, and then chased it with proctoring. And I said absolutely because yes, it is true that she may have had some kind of awareness pre-intubation, but she was hypoxic.
Yeah.
What we need to do is fix the hypoxia.
Right.
And so the dogmatic, like you have to give a certain dose and you have to do this. I think it just really depends on the case. So I wouldn't say never do this or never do that. I am a big proponent of using ketamine, 1 to 2 milligrams per kg, but I'm also teaching my folks we need to resuscitate well before we make that decision of taking it away. So it depends, right?
What are you doing for medical patients? Anything different?
Well, we have levothyroxine, we have epinephrine, we're going to pressors early.
Yeah.
And so our folks are doing that. We usually have longer transport times as well.
Okay.
So, but yeah, they were very quick to start a pressor grip after a short fluid challenge.
Good.
Most of just floods.
Right.
But I think not all EMS systems are able to do that. So.
Right. No, I love this.
Yeah.
Anybody? Yeah.
I just wrote one quick comment on the airway. We were talking about this at SOMA last year, positive pressure, and just giving combat medics pediatric BVMs.
Yeah.
I mean, because it's 500, right? You're not getting 1,500 and slamming it.
Yeah.
If you're not always practice your BVM skills, you just give them pediatric. Isn't that just good enough?
No, I think that has to be, for a military size individual that's in shape. I think that's a perfect approach. I think from a standard EMS standpoint, where you're dealing with bigger individuals, high, big chest compliance, a lot of heavy weight on the chest, sometimes that doesn't work. But I think that's a small percentage, and I like. Did you guys ever switch from adult to pediatric BVMs? I know you guys are always pretty forward thinking.
For adults?
Yeah.
We still use an adult BVM.
You just retrained.
Eric,
Yeah.
one of the things that we use in kids, one of the biggest differences that may be relevant to this conversation is most of our pediatric anesthesiologists do not use bag masks. They use what we call them Mapleson. I don't know if everybody knows what a Mapleson is, but it has a valve that allows you to not overventilate the patient. No matter how hard you squeeze, you set the valve, and so and many pediatric anesthesiologists will not use a bag mask because of the reasons that you described. And I'm just wondering, maybe that's something that the adult guys could.
There are a few products out there. There's a product that's called the Goldilocks valve. It actually is now part of Pulmodine. That does exactly that. It limits the volume. But the problem is like getting the have you heard of that? Yeah, I mean, getting the products are more expensive, right? So getting the price down per unit to where you can do that. Yeah.
Yeah, it's interesting in the UK. Thanks. In the UK in the late 90s, we had the Marshall bag,
Okay.
which was only 750 mils.
Happy medium.
And it got some traction and then just died away. And there were a few studies that showed that there just wasn't any difference between using that and the standard bags. So it just kind of died a death.
Yeah.
Using the paediatric bags is a great idea. What we tend to get the guys to do, because of the amount of weight and space and what have you, is we just get them to keep the bag folded in half.
Yeah, and we've been trying to retrain underhand technique, couple fingers, right? You know, trying to. But for some, that's still difficult, right? It's not ergonomically. We lose a lot of strength by rotating our wrist. Love the dialogue, guys. Anything else? Anything on this acronym that we could change? Always looking for feedback. You know, like I said, I'm going to write a paper on this and publish this. I think it's a big deal, but hey, if I'm missing something, if there's other ideas, would love to hear that.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.